nearly 8 o'clock, and if there are any, and I had a quick look, it doesn't appear to be, but we did invite some people that were interested in hearing our guest speaker speak to tune in at 8 o'clock. So if anyone is there that has joined our meeting to hear our guest speaker, we're welcome. You can email the office and we'll send you an application form to join the club if you feel that it's worthwhile. But I'd like to introduce Associate Professor Nathan Lawrentschuk, MB, BS, PhD, FRACS in urology. He's a urological surgeon and urologic oncologist with appointments at the University of Melbourne, Department of Surgery, Peter MacCallum Cancer Centre and Olivia Newton-John Cancer and Wellness Centre at the Hospital, Melbourne. Nathan is the director of the E.J. Whitten Prostate Cancer Research Centre at Epworth Hospital in Melbourne. He completed his PhD in kidney cancer, as well as 2 additional years of training in robotic, laparoscopic and open cancer surgery at the University of Toronto, Canada at Princess Margaret Hospital, the world's 5th largest cancer centre, obtaining a Society of Urological Oncology Fellowship. Nathan has a special interest in cancer, high-risk surgery of the prostate, kidney, bladder and testes, as well as being comfortable with active surveillance of many cancers where appropriate. In addition to his additional specialised qualifications, he has published over 400 peer-reviewed papers and book chapters. He is an associate editor of the BJU International and World Journal of Urology, editor of the USANZ Supplements, while he serves on multiple journal editorial boards and speaks at multiple international conferences. I don't know how you get time to mow the lawn, Nathan, with all that work you obviously have on your plate, and how you keep up with all those hospitals you're involved with. But ladies and gentlemen, over to you, Nathan.
Thank you, Peter, and thank you to the MelbPC users group for having me along today. It's a real pleasure to be here. Hopefully I'll be able to share my screen with you as I go through a talk, and I believe there'll be some time for questions at the end, Peter, is that correct?
Yeah, sure.
Sure, okay. All right, I was actually chuckling to myself 10 minutes ago because I just updated my talk, and of course my computer crashed and it failed to save any of my changes. So,
oh no.
Anyway, not to worry. There were only a few little extra bits and pieces I'd specifically put in for you guys. But anyway, there you go. Maybe I should be a member of your users group so I could learn how to not make my PowerPoint crash. But anyway, a common problem, I suspect. All right. So without further ado, I'll carry on if you like. If I can just get my slideshow up and running. Sorry, no, I'm not sharing my screen, am I? You'd think we'd be good at Zoom after 101. All our meetings at hospital have all been Zoom now for almost since March last year. So we should be well versed with this, shouldn't we? All right. Everybody can see that now?
Yes.
Yes. No worries.
Stuff.
All right. So thank you for the kind introduction. I'm very, I actually saw Bert on the screen before. I'm grateful also to Bert for personally inviting me to your group. As you mentioned, I subspecialise in uro-oncology. I did a 2-year fellowship in Toronto. Currently, you can't keep up with my hospitals because I'm now the Director of Urology at Royal Melbourne. I should update my CV. And I do work as the Director of the E.J. Whitten Prostate Cancer Research Centre at Epworth. I am interested in research and treatments that have maximal impact and minimal side effects. My brief tonight was to talk about modern technology with advances in prostate cancer research and treatment. And I think I wanted to really go through from prostrates to nanoknife. I'm still surprised how often men do refer to their prostrates, but I think we all know it's prostate, but it still comes up. Another aspect I wanted to think about was from targeting to battleships to the electric chair and back to targeting, and that'll all make sense in a little while. So just a reminder that prostate cancer affects 1 in 6 men in Australia currently. That doesn't mean 1 in 6 men will die of prostate cancer, but it does mean 1 in 6 will likely be diagnosed. And if you have a strong family history, particularly a first-degree relative, a brother or a father, then you increase your risk 2 times. If you have 2 relatives, you increase your risk 4 times. And the younger your relative got the cancer, the higher the risk is that you'll be affected. So it still is a very common disease. Fortunately, I'll come to the point where I can explain to you that indeed most of the prostate cancer we treat is watched these days. We don't go in and rip prostates out or radiate them like we did when I first started urology back in 2002, which I'm sure you'll be relieved to hear. For those of you who may not be completely familiar, the prostate is an organ here that is about the size of a horse chestnut or a mandarin. It lives nestled between the bladder and the pelvic floor, and the urethra is a tube which passes through it and out through the penis. The prostate is an interesting organ because it really serves 2 functions. The first is to provide food for sperm, and that's one of its main functions as an exocrine gland. But also as an endocrine gland, it's where the body converts testosterone into super testosterone, and that's one of its other endocrine functions. It also serves to cause men a lot of problems as we get older. Unfortunately, you'd think after our reproductive years, it would just shrivel up and take its place at the back of the stores. But in fact, often it gets bigger and causes problems, which is the opposite of what we would like it to do. It's a true gland. It's made up of glands plus smooth muscle, and that allows it to have an anatomic function, but also a dynamic function. In other words, it can actually actively squeeze and impact on the urinary tract at times, and relax, of course, as well. Surprise you that not everyone knows where the prostate is. And in fact, 60% of men in the United States didn't know that prostate sits underneath the bladder. I suspect the number would be fairly similar here, but the point is that a lot of men, we're not taught about it. I wrote an article about it last year. I've been to 2 of my son's sexual education sessions. They happen to mention it at times up to 9 or 10 organs in women, and usually only 3 in men. And the prostate isn't one of them. So it's not surprising at a young age we tend to ignore teaching where the prostate is and what it does. I tend to like to simplify the roles and how these things work. And for me, the prostate is an organ, as I said, it's nestled here. I like to think of it like a balloon going through an orange. Now, the reason why I think of it like that is that indeed the balloon is the bladder, the straw is your urethra, and the orange is your prostate. Now, why is that important? And I'll come to why that's important in just a moment. It's extremely important to conceptualize what the prostate does. So when we look at a normal prostate, we've got a nice channel going through it, and we have the prostate sitting beside it. This is where it's been bivalved. As we get older, if we get benign disease of the prostate, if you think of this orange or mandarin, the rind is on the outside and the pith or the fruit is in the middle. The fruit gets bigger and that pushes on this tube, and that causes a lot of symptoms for men. That's benign disease of the prostate, and that's a classic symptoms that many men may know people with. It causes those obstructive symptoms. It causes the stream to have poor flow, weak stream, but it can also cause, believe it or not, irritative symptoms because the bladder is pushing against this obstructive prostate, telling us to go to the toilet when we can't go, and also retaining urine. And ultimately, the worst complication, of course, of this growth is the inability to pass urine at all. So I just always like to give that as a bit of a background, because we want to stress that prostate cancer and benign disease of the prostate are 2 different things. Benign disease of the prostate affects 80% of men. It is no way cancer related, but does cause a lot of symptoms. And there are many treatments for this, ranging from medical therapies with tablets all the way through to lasers and rebores, as a lot of people like to call them. and very effective treatments. So men need not be concerned with these things in the sense that, as we say, well, we get these symptoms when we get older, but they can be treated and they're not cancerous. However, as I mentioned to you, if we think of the orange model, cancers tend to occur here on the outside of the orange. And you can imagine that they have to get extremely large to push on the middle of the orange and cause symptoms. So the cancers here, here's a tumor here, they're often right at the periphery. They're nowhere near the straw or the urethra. So that's why it's often called the silent disease, because a lot of men I diagnose, in fact, most of them say, but I don't have any symptoms, doctor. Well, you don't, because these tumors are not pushing on the urethra or the tube that takes urine from the bladder to the outside world. Why do I believe in research, and why do I believe men should be educated about prostates? Because I think it's important that as men, we take control of our own health and captain our own ship. But also I think research is really important, because what it's taught me is that we can change. And, you know, Melbourne's skyline looked different 10 years ago as it did 20 years ago and 40 years ago. And sometimes there are little incremental changes in the skyline, but sometimes we can have a giant leap in technology, and that can bring us a long way forward. And mostly in medicine, we go with these small incremental steps, but sometimes we get these larger ones. For me, treating mostly cancer, there are three main branches that treat cancer. There's surgical oncology, surgery to biopsy and also often to remove the cancer. There's radiation oncology, to irradiate tissues to destroy cancer cells. And there's medical oncology, which is giving systemic therapy, so chemotherapy and things like that. And in the middle, obviously, we all join together on what we now call multidisciplinary clinics, but we also can come together and do good research. And I think at the end of the day, what we really want is really good, optimal patient outcomes. There are challenges in prostate cancer and areas rife for research at the moment. I'm happy to take questions later, which I'm sure I will, about prostate cancer screening. It's a very controversial area. There are no programs like Breast Screen set up in Australia currently, not likely to be in the future, and I can detail that later if you like. Why I think men over 50 should be screened, or 10 years before your most nearest relative. So in other words, if your father got prostate cancer at 43, you should be screened in your 30s, while if they got it in their 50s and their 40s and so on. But if you have no family history, you should be screened at age 50, possibly earlier, to get a baseline PSA. And I think there are significant advantages of that, because most cancer we treat is in fact favorable cancer. In other words, we watch it, but we really want to get the bad cancer. So that's where I think we can have an impact with screening, but it's really at a it's not going to be getting a caravan set up anytime soon. The numbers just don't stack up, but I can answer that later. I think there's new prostate cancer imaging with MRI and PET scans, which I'll briefly go into. And then pushing the boundaries. Do we always have to take it out when it's significant cancer? Probably not. Probably not. So firstly, believe it or not, when we diagnosed prostate cancer up until a few years ago, you had an elevated PSA, you might have a nodule on rectal exam, a urologist would book you in for a biopsy, and we would effectively do a grid or blinded biopsy of the prostate. Ultrasound would guide us, but not really guide us to anything in particular. Along came a thing called multiparametric MRI, which I won't bore you with the details, except to say that there are different phases we can put MRI through, which is a large magnet. It sucks water in different directions and creates somewhat slightly fuzzy pictures, I still believe, compared to a CAT scan, but nonetheless, they're extremely important. Here's a prostate here, and even you could see here this charcoal-looking lesion, which comes up in different phases of the MRI. It's white there, it's charcoal there. That is a high-grade prostate cancer, which is quite visible on MRI. Why is that important? Well, MRI is non-invasive, and we can use it now as a screening tool. So instead of PSA, rectal exam, urologist, biopsy, now it's, before we do a biopsy, let's do an MRI, because we may well not need to do a biopsy. Or if we do a biopsy, we can now target that biopsy appropriately. Second aspect of diagnosing prostate cancer is, in fact, the biopsy itself. This is where the battleships come in. We use this grid here to help target different parts of the prostate, but also we can use the grid along with ultrasound to find those areas we found on the MRI because of the configuration of the prostate. You see here a tumor here that might light up on the MRI. We would make sure our needles are going through this part of the battleships to get to it. Now, why is that important? And here you can see here somebody using, again, a biopsy needle through this grid. In the past, we used to biopsy through the rectum and do what were called transrectal ultrasound-guided biopsies of the prostate through the rectum. That carried with it about a 3 to 4% infection rate. Because with this biopsy method, we go through the skin, we reduce that sepsis rate down to 1 in 3 to 4,000, very low. And then when the infections occur, they're very treatable. The ones through the rectum were quite tricky to treat at times. So you might have heard of these stories of people getting infections and so on. They're very, very rare these days. The biopsies are much more accurate. We can target parts of the prostate that are difficult to access previously. So MRI and transperineal biopsy are both freely available and funded in Australia. MRI is funded by the federal government. We lobbied the government, and that's been funded now for just over 3 years. Transperineal biopsy has always been funded, but has had additional funding put into it more recently. So that's pretty well standard of care for diagnosing men with prostate cancer. In the past, as I mentioned, most treatment options when I started were, well, we found a little tumor, let's take out the whole prostate or irradiate the whole prostate. That's radical therapy. That was because it worked, that's true, but there are side effects of any treatment, whether it's surgery or radiation. So what we decided was, is there a way to do, and why is it important? I should say, just stress to you, this is the prostate, the seminal vesicle, which I haven't mentioned, a little gland, and the bladder, but the nerves that supply erections come right alongside the prostate. So they can get damaged by surgery or radiation, and the pelvic floor sits just here. And again, that's important for our continence and things like that. The rectum sits just behind. So that's why this is important. What about focal therapy? To switch gears again, to come back to our theme of targeting. Well, what would focal therapy be? Focal therapy would be recognizing that there's a tumor here and then saying, why don't we just treat that little part of the prostate and a little bit of a buffer zone around it rather than treating the whole gland? A bit similar to the concept for breast cancer. In the old days, they took out whole breast for small breast cancers. Now they just take out a little lump. Same concept here. Let's just treat that part of the prostate. And what's allowed this concept to develop is that MRI has improved and other imaging as well. Our biopsies have improved and so on and so forth. So we can now think about focal therapy in certain men, not all men, but certain men. I've published a lot on focal therapy here. I focus your attention here on what we think about focal therapy or focal ablation. The definitions differ. Sometimes overseas, they say sparing a quarter of the prostate with the nerves is focal therapy. Some people say treating half the prostate is focal therapy. I believe true focal therapy is just treating that focal part of the prostate and a little bit of a buffer around it, meaning that the impact on surrounding tissues and organs is absolutely minimal. So I think it is an emerging treatment for men, not only men who've just been diagnosed with some prostate cancer, but also for men who've had radiation and failed that treatment, we can utilize it. Now, why would this work? Well, when a lot of you may understand and probably heard, there's multifocal cancers, that they're not always in one part of the prostate. So what we tend to find is that there can in fact be about 30% or up to a third of people who have one small tumor, like I showed you before. If we treat that, we've treated your cancer. There's also the index theory of tumors. In other words, there's a main cancer in the prostate here and a little bit of low-grade tumors elsewhere. The low-grade tumors will never develop and metastasize. They can be left well alone, just much like bowel polyps are for men and women who go in for bowel cancer screening and they find polyps. As long as they're got early and maintained, they're not going to cause trouble. But the index tumor is the one that's going to potentially go outside the prostate and cause cancer. So that's basically the Gleason 6 cancers or low-grade cancers cause noise. The index tumor is really the main one we want to treat. So that's why the whole theory of treating this focally holds up in many patients, but not all of them. We talked about harm minimization. Here, another example of an MRI. And in fact, this person had agreed to actually have focal therapy before they had their prostate out. A friend of mine did that in the Netherlands, which was a really interesting trial. But indeed, what do we think about is, well, most men who we diagnose with low risk, low grade prostate cancer. we watch them. We put them on active surveillance. We don't treat them. So what would focal therapy be? We'd think of that as a thing called surveillance plus. In other words, it's really watching them carefully, maybe a little more often, but it's rather than going for those radical treatments of surgery or radiation. As I said, it is treatment, but it's focal with harm minimization. The real strength is that I'll talk about these numbers now, I suppose, for you. We confuse people in prostate cancer. Just think of them like traffic lights. We have green cancer, which is Gleason 6 score. We have 7, which is amber cancer. And we have 8, 9, and 10, which is red cancer, high-grade cancers. So we talk about these Gleason scores, but I would only refer to you in this talk and forever as either low risk, intermediate risk, or high risk. And it's really some of the intermediate risk and the high risk ones are the ones we want to really treat with radical treatment. But many of the Gleason 7 cancers or intermediate ones can be watched. The Gleason 6 ones, as I said, are like bowel polyps. We just watch, we don't do anything for them. We don't need to treat them focally. We just need to watch them. So I think the vast majority of cancers we deal with can be watched or potentially treated focally, leaving the radical treatments for the ones that really need it. The pitfalls of any focal treatment are, could we have missed a window of opportunity? In other words, we've just treated that area, but did we miss a small area of high-grade cancer because our imaging and biopsies are not perfect? They're very good, but not perfect. But in fact, we believe, based on the data, certainly you can salvage a lot of these focal cases, provided they're monitored appropriately with imaging and repeat biopsies. In other words, we might delay radical treatment for 5, 10 years, maybe longer. We might cure some of those men, but we believe that we've got an opportunity there to salvage the situation should that they progress or have been understaged in the first instance. We can also use it, as I said, following radiation treatment, but I won't bore you with that. Now, there is another imaging modality I wanted to mention. We've talked about MRI, multiparametric MRI, which is using magnets. There's another type of targeting imaging, which is called PET scanning. You may be familiar with PET scanning, positron emission tomography scanning. That uses the release of small positrons from a small amount of radioactive material, which is injected in the body, circulates, and then targets areas. Many of you may have known someone who's gone for a PET scan in the last 15, 20 years. 99% of PET scans are done using glucose. The concept is that cancer cells turn over faster than the rest of the body. Therefore, if you have radioactive glucose accumulating in an unusual part of the body where it shouldn't be, such as in the brain or the stomach or somewhere where there's food, or where you have high use like the heart, in other words, if there was an accumulation of glucose somewhere, that would indicate potentially a tumor. Now, that's a pretty broad stick. What's happened in the last 5 years is we've started to develop targeted positron emission tomography, which can actually hone in on specific cells even, and cells that express certain things. So PSMA stands for prostate-specific membrane antigen. That's an antigen expressed by prostate cancer cells. And you can see here in this photograph of a scan, this person's prostate is lighting up in the base green because they've got an overexpression of this PSMA. Now, we've never had this ability to look inside the prostate apart from with MRI, but this is a really unique opportunity to look for lymph nodes, avoid bone scans, which used to be done in the past, because we know that a lot of false positives occurred, and we can be really specific about prostate cancer. And this can be combined with MRI in a great way for us to really be certain about patients who should be having things like focal therapy. So with this patient, we would, as I said, treat that area and a little bit of a buffer around it. And also, you would treat that without causing potentially symptoms of urinary nature, sexual nature, and other potential side effects. Which modality should we use for focal therapy? Well, let me tell you, pretty well everything in the kitchen's been tried. Cryotherapy using freezing, microwave therapies, photodynamic therapy, you name it. A lot of them, laser therapy, a lot of them make heat to kill the cells, but that can also have secondary impacts on nearby nerves and other things. High intensity focus ultrasound's another one. So the problem is using thermal treatments, you can overcook or overfreeze, which can lead to potential side effects. Now, the real thing I wanted to focus on was this concept of electroporation, which I'm sure with such a diverse group as you, some of you may know a little bit about it. But basically electroporation has been known about since the 1700s. Electric, firstly with electric sparks that cause red spots on human and animal skin. Galvani did some famous experiments in the 1780s where they were able to use electricity to stimulate the spinal cord of frogs. Lightning strikes and then high voltage electrical currents purifying water and things. So electroporation has been known about for a long time. So passing electricity through tissues or other potential places like water. So what was found about the concept of electricity was that it could kill bacteria. Now, how did it kill bacteria? Well, it didn't cook them. What it did for the bacteria was it actually disrupted the cell membrane, such to the point that water leaked inside the cells swelled and they burst. So it wasn't anything to do with heat, which we associate with electricity and bushfires and lightning strikes. This is low dose electricity, which can disrupt cell membranes. So I think that's when this concept really came to the front in the 1950s. The mechanism is, as I said here, passing electricity through the cell, and then we break the bilipid phospholipid bilayer of cells, allowing them to be mopped up by the body's immune system. Here's an example using a normal liver and then showing the small pores in the liver cells from nanoknife treatment or focal therapy with irreversible electroporation, or we call it IRE for short. Now, there is a thing called reversible electroporation, which is where you put enough electricity through the cells, but the cells will be able to repair themselves. Now, that's a natural mechanism we have to repair from injury, and there's a certain threshold where that will occur. Of course, irreversible is different. So irreversible is when we take it just that little bit too far, where it can't be repaired. So what's interesting about this IRE or irreversible electroporation is that indeed the cells of the prostate are favoured to be electroporesed over other important cells nearby, like nerves and blood vessels. So there is a propensity here with the right level of electricity to theoretically spare the nerves, spare the blood vessels, but destroy the glandular cells like in the prostate. The first trials of IRE or irreversible electroporation were performed in dogs, and they were done on dog prostates, and they showed no incontinence, no erectile dysfunction, and no damage to adjacent structures. So Scooby-Doo was quite happy. And that's when the concept was taken further to human prostates. Could we do it? And some interesting trials were done in the Netherlands where they actually did irreversible electroporesis in men, had prostate cancer, and then took their prostates out. What you found was that if you took these prostates out of the men who were in these trials, you could carefully see this zone of treatment where the needles had been placed. You placed the needles in, I'll show you in a moment, and you could see clearly that there was prostate cancer death from this IRE treatment. So the key points for IRE is it targets the cell membrane, you preserve connecting tissue structures, it's non-thermal, and the reason the cells are mopped up and killed is by naturally occurring apoptosis or necrosis, which is the normal body's reaction to cells that have effectively died. Here's a lot of data on IRE. I won't bore you with the fine details. Suffice to say that a lot of places are researching IRE at the moment as a treatment for men with prostate cancer. A largest trial has 270 patients in it, and that included primary and redo. And what I wanted to focus on here are the functional outcomes, that 99% of men got away with excellent or perfect continence, and around 90%, up to 90%, I should say, preserve their potency or erectile function. And that is often in men who already had poor erectile function to start with. So I think the results were incredibly encouraging. As I said to you earlier, we talk about the tumor lesion, ablating that lesion with a buffer, and so on. What could happen, as I said to you, one small risk is we could treat that part of the prostate, but then another cancer may develop out of field or in another part of the prostate. That's something we watch for with repeat MRI, sometimes PSMA PET scans, and repeat biopsies. So we try to keep an eye out for these out of field occurrences. Functional outcomes, as I said, are very good. Here's an example. There's a prostate cancer here, this grey area here. This is one of our patients who was treated 1 week post-treatment. You can see the swelling and the changes on the MRI. And here, 6 months later, you can see that area has shrunken down and basically disappeared. And this patient had no functional problems at all. Their PSA dropped and a biopsy proved that there was actually no active cancer in them later on. Doesn't always happen as good as that, but we always want to show in these talks our best performing patients. So how does it actually work, this nanoknife treatment? We have a machine, the nanoknife machine, which costs about $350,000. We have an activator probe, which has to be used in the whole circuit to activate it, and then the standard probes. And what we do is we, as I said, we use MRI and sometimes PSMA, or more often PSMA, to target these areas. There's using the ultrasound in theatre. There's our battleships. We go in, we put the needles into the prostate under ultrasound guidance. We can see where those needles are. There's 5 needles in this patient. You can see the 5 needles there. The concept is that the electricity will go between that, the different needles. So from that needle to that needle, that needle to that needle, there and there. And by this crisscrossing formation, we will form an area of electroporation around here. And it goes about 5 millimeters outside that circuit. Here you can see here what I'm talking about. The different measurements are made of the distances between the needles, and that area is targeted with about a 5 millimeter buffer around it. That's carefully monitored on the machine to make sure the voltage of each shock that's given. We typically give around 90 to each pair of electrodes. We maintain the probe spacing so that we get good overlap between the areas of destruction of cell membrane. We watch the current carefully so that we don't go too far, and the computer is quite sophisticated and has inbuilt mechanisms to stop us from causing too much heat in the tissues. As I said, you can adjust the current to the point where there's reversible electroporation and then irreversible. In other words, we have to get that current up to around about 30 amps to achieve that. I think there are certainly advantages of this type of treatment over other ones that have been tried before, like cryoablation or HIFU. It's reliable. We know that from the studies in humans. It's a quick day surgery procedure. It is repeatable if required. We get preservation of structures, and you can still salvage the situation with surgery, for example, later on if the patient was to progress. In other words, if in 5 years had worse disease. The disadvantages is the cost. The machine's expensive. The needles are expensive. In fact, the needles went up, and they come from the US, up to $20,000. We have got some data and some good money for research. We're running through the Epworth at present. We're lobbying for an MBS item number so that health funds will cover it. But at present, we're still in that process of getting good data, which we have, but this takes many years. Through the Epworth Oncology program, we're still funding patients who've failed radiation, and we're still doing primary patients. We've now done 50 cases, which will be published later this year. So that's me with the machine at Epworth. It's about that big, the machine. And that's me with Alex, one of our researchers, conducting the focal therapy. So as I said, in summary, we don't want to kill the low-grade Gleason 6 cancers. We want to kill these 7 and above ones in a tight zone with low morbidity, in other words, fewer side effects. We may cure some men, but we think we can push the can down the road so that patients can avoid radical therapy, turn radical therapy into active surveillance. I'll leave it there because I've just come up on the time. I could talk for hours about these areas, which are very close to me, but I want to thank the PC users group for having me along today. And I'm sure I may have generated more questions than answers. So I'm happy to take those questions from you all. I'll hand back to you, Peter, or whoever's, I assume, Peter, you're the chair of this meeting.